So all of these components come together to determine an individual's uh, health trajectory. And this is highly very variable as we grow older. The WHO has proposed 3 stages to the health trajectory. It starts with a period of high and stable capacity in early adult life. And in middle life, it starts to decline. And in later life, there's a significant loss in your intrinsic capacity, which often it's associated with frailty and increased care dependence. When we consider long-term HIV survivors, using this framework, young adult HIV survivors who acquired HIV as postnatally, and they are now in their young adults in their early 20s, by definition would fit in the first category of intrinsic capacity, where your intrinsic capacity is expected to be high and stable. Now, some adult milestones that correspond to this life stage include completing higher education, starting and maintaining employment, independent living, starting intimate partnerships, developing social networks, as well as financial independence. But there are many studies now which have been published to show that in many young adult HIV survivors experience poorer cognition even in their young adulthood. They often have metabolic changes which impact their vitality, as well as experience high degree or a lot of issues associated with mental health as well as substance use. But how does this then impact their functional ability? And there are very few studies which have looked at this in the context of young adult HIV survivors. But one study in the CASA cohort based in New York explored the medical and functional outcomes of young adult survivors with a median age of 23 and compared it to HIV exposed but uninfected individuals. And these are individuals who grew up in the same circumstances but without HIV. And in this study, they found that young adult survivors had poorer cognitive scores, and a higher proportion of them were seeking treatment for mental health issues. But when they assessed functional outcomes, this was comparable in both groups in terms of starting families, sexual relationships, employment, as well as education. Now, a more recent study in the facts cohort, also based in the US, has reported similar findings as well. Now, what this sort of tells us or implies to us is perhaps that at this early stage, despite having changes in intrinsic capacity, functional outcomes may still be preserved. And perhaps it's a window of opportunity for us to think about how we may intervene early in order to prevent future changes in health decline. Now, it's important to also think about how living with the virus for decades can influence how HIV survivors interact with their external environment. Recalling that an individual's functional ability is both the product of intrinsic capacity plus their external environment. And there are many circumstances associated with living with HIV which may not be conducive in minimizing the impact of intrinsic capacity loss. And some examples include stigma and discrimination may discourage young adult survivors from attending clinics, particularly as they transition from pediatric to adult clinics. Many young HIV survivors also have poor social capital and family support due to losses from parents and grandparents who cared for them. And this can lead to poor ability to navigate emerging health as well as other life stresses. In some countries, there are also discriminatory health policies, like in Malaysia and many other countries in the Asia Pacific region, where health insurance doesn't allow them to access health financing for HIV and mental health services. And so this is an additional financial stress for them as young adults as they're trying to be financially independent, because this becomes an out-of-pocket expense for them. So many of these external environments are challenges that may impact the future trajectory in terms of how they grow older. So the second stage of WHO's model for healthy aging is where intrinsic capacity starts to decline, and this is often seen in midlife. And important adult milestones at this point include late parenthood, work advancement, roles of mentorship, disease onset, as well as changes in physical appearance, as well as cognitive processes. Now, in this context, we have a lot of evidence to show that older people living with HIV have got changes or declines in the intrinsic capacity almost in every domain, in multiple studies done in high and low income settings, as well as in cohorts which are male or female. But even at this stage, the evidence from the general population states that when if your external environment is supportive, you can actually minimize or slow your decline in functional ability. But in the context of HIV, there are some challenges that are unique to a person living with HIV. For example, having to access specialized care at a younger age, having been diagnosed with multiple comorbidities might be an issue, either due to health financing or due to the fact that, some of these services, particularly in LMIC settings, where some of these services are only available in tertiary centers, which are not really accessible to them. There are competing time commitments for family, as well as work commitments that may limit their access to, and they may not want to attend clinic services. And treatment fatigue is something that's very well established in the context of long-term HIV survivors, and as they get diagnosed with multiple comorbidities and have to take multiple medications, adherence issues would be a problem, particularly with polypharmacy. And the final stage, of course, is when there's a significant decline in intrinsic capacity, and this often corresponds to increased care dependence, having difficulties in taking medications and preparing meals, and so on and so forth. This period often corresponds to important adult milestones like retirement, social isolation, increased care dependence, ageism, concerns around that, and a subjective sense of well-being. Now, similar to the literature in terms of declines in intrinsic capacity, we have quite a lot of studies reporting declines in functional ability in people with HIV, both in high and in low middle income settings. But I do want to draw attention that we actually have very limited studies in women, particularly those around LMIC. And this is an aspect that we need to address in future work that we do. In fact, in a lot of our understanding of the phenotypes of growing old with HIV, a lot of the studies have come from high-income settings. And there are very few studies that have been done in LMIC settings, and far fewer that have explored the context of aging, or the perspective of aging from a life course perspective. The work that we did in University of Malaya, we recruited people living with HIV who were returning to our clinic as part of routine care, as well as community joining individuals as controls. And in this study, we assessed some aspects of intrinsic capacity as well as functional ability. And the participants, the inclusion criteria was age 25 years and above. Those with HIV had to be on antiretroviral therapy and with undetectable virus for at least a year, and didn't have any acute illness at recruitment. Now, in this analysis, we found that the frequency of people, the proportion of participants with HIV with deficits in the intrinsic capacity and functional ability was much higher compared to age, sex, and ethnically matched controls. And in changes in intrinsic capacity tended to co-occur in the same participants, in the sense that when we looked at it as a burden, there was a significant difference in people living with HIV compared to those without HIV, even after adjusting for confounders. Now, though this study wasn't specifically done in long-term HIV survivors, we still documented deficits in people in their 20s and 30s, really highlighting that when we do studies of aging, but only in people over the age of 50, we miss the opportunities to identify how we may intervene early in order to change the trajectory of health much later as they grow older. So we also spoke to the community to try to understand what were some of the issues that they were concerned with in terms of some of the environmental factors that they were concerned with as they grew older. And some of the issues that they would raise were with regards to lack of family and social support, as many of them were estranged from family and friends and were concerned about who would care for them as they grew older. There were also concerns with regards to the lack of informal support systems in the sense of many of the palliative and assisted living facilities in Malaysia are not part of the formal healthcare system, and they are privately run. And so many of these assisted homes or assisted living facilities would not admit people or have discriminatory policies where they don't take in people living with HIV. And even if they do, it's very expensive because it's profit driven. And this becomes an issue as they grow older on who will care for them. There were also concerns about death and dying and preserving their confidentiality as well as their HIV status at the end of life, because many of the providers for these services in assisted living facilities and funeral services may not be sensitized to the issues related to living with HIV and may inadvertently disclose their status. So having spoken to the community, we had the opportunity to work with the Malaysian Research Institute on Aging, and they were about to embark on a survey where they were trying to understand the challenges of running some of these assisted living facilities in Malaysia. And although their survey instruments were already sort of finalized, they agreed for us to include some questions as part of the survey so that we could understand, at least get some idea of some of the issues that were raised by the community. So this study is actually ongoing, but I think the results that we have so far is quite telling as it is. So we included some questions to try to understand the premise practices. And to the question, are residents required to undergo full medical checkup and make a full disclosure of their health status prior to admission? 99% said yes. Does the premise have any guidelines on protecting confidentiality and disclosure of resident status? 96% said yes. Does the premise accept residents with bloodborne virus infections such as hepatitis B, C, and HIV? 6% said yes. Does the premise carry out need assessment and develop individualized care plans for each resident? As we know, it can be quite critical in the context of HIV because there are different issues to address with. Only 43% said yes. When we explored, does the premise have any older adults currently living with HIV at the point of the survey? Only 4% said yes. So this was quite surprising to us. We didn't expect this. I mean, we knew there was an issue, but we didn't expect it to be at this level. So we're waiting for it to, the survey will end at the end of this year. But it, for the first time, will give us, hard evidence to speak to policymakers in terms of how we can address this issue and perhaps get a little bit more funding to understand what is the hesitation behind some of these responses. And I think from informal sort of engagement, I think it's just a poor understanding of the risks, and it probably needs just a lot of training and reassurances. Just to very quickly summarize what I've gone through so far. Long-term HIV survivors have chronological ages that span the entire adult life course, with age-related changes actually being reported in almost all age groups. And so when we think about the context of aging with HIV, it's really important to do this as a health trajectory across the adult life course. living with HIV presents with unique environmental challenges which may adversely impact an individual's health trajectory, and something that we need to consider. And we need more studies that focus on long-term health for people with HIV from LMICs, particularly where it really helps define a composite outcome of physical, psychosocial, and functional capacities. So just very quickly in the last part of my talk, I will touch a little bit on some opportunities for interventions in order to address health-related decline. And I want to use the findings of a recent study to sort of frame this discussion. Now, at the start of my talk, I shared with you this study, which was done almost 10 years ago, where the investigators from the HIV cohort based in the Netherlands documented cross-sectionally the burden of chronic comorbidities in people with and without HIV. Now, they recently published a study where they explored the health trajectories in the same participants that they followed up for a period of 6 years. Now, in this analysis, they found that despite people living with HIV having a higher frequency of chronic comorbidities compared to those without HIV, the number of new conditions occurring over the period were the same, both in people with and without HIV. However, the higher number of chronic comorbidities in people with HIV was attributed to a higher risk of death, over 3 times for each additional comorbidity compared to controls. The impact of HIV on the trajectory of health was more obvious when the analysis was done based on disabilities associated with having these chronic comorbidities. This was measured using disability-adjusted life years, or DALY. And DALY is the loss of healthy years of life from having a particular chronic comorbidity or years of life lost due to premature death. Now, in this analysis, and as shown in the graph, you can see that the healthy years of life loss was significantly higher in people with HIV as they grew older compared to controls. And this difference was largely attributed to mortality from non-AIDS-related malignancies and MCPs. And in sub-analysis, people living with HIV with the greatest loss of DALYs were those who had prior history of late presentation to care, who had a history of AIDS, and those who had an exposure to toxic NRTIs like stavudine, didanosine, and zalcitabine. And I think this finding has got significant global implications because it essentially explains the majority of people living with HIV in local settings. This profile describes 70% of people living with HIV in Malaysia today. So it really has got a huge impact in terms of thinking about how this group is going to age in current years. So this study highlighted 2 key points for me. And the first is that the increased burden of mortality in people with HIV was due to non-AIDS defining events and malignancies. And this outcome is addressable with prevention and with preventive screening as well as early intervention. And the second point was that people living with HIV experienced a greater disability as they grew older, despite acquiring the same number of chronic comorbidities as those without HIV. And these greater disability likely translates to poorer quality of life, poorer function as well. And these are 2 health outcomes that we rarely assess in our clinic settings, often because we are very focused in monitoring disease-based parameters. And I think the findings from the study offer us an opportunity to really relook at the gaps in our current care and rethink how we might optimize care in people with HIV across their life course as they age. And I want to touch on 2 aspects. Optimizing prevention and screening for NCDs and malignancies. I think we have a lot of acknowledgement that people with HIV have increased burden of these conditions, but our prevention practices and interventions are still lagging in things. This is an example of a study from the EuroCIRA cohort where they explored the cardiovascular risk profile of participants in this cohort, which is from over 100 HIV treatment centers in Europe. And 1 in 5 participants were noted to have a moderate to high family risk score. And the other HIV cardiovascular risk factors were also, the frequency of the other cardiovascular risk factors were also very high. The participants' records in the study were then prospectively followed up to assess rates of successful modification as part of clinical care. And what they found was that despite having a good viral suppression, which essentially indicated good HIV care engagement, the successful risk for modification for the other cardiovascular risk factors were really quite suboptimal. And similar gaps have also been noted with non-AIDS defining cancers as well. And this is a study that looked at screening for cancers or non-AIDS defining cancers in a cohort in the DC cohort, which is a hospital-based cohort here in the US as well. And individuals were deemed at risk of cancer if they didn't have a prior cancer. And those eligibility for cancer screening was determined based on published guidelines. And across all the different cancers, we can see that those who underwent cancer across the follow-up period of 6 years were really quite suboptimal. And overall, less than 60% of eligible participants were screened, despite receiving care in a tertiary care center. Now, this study, as well as the prior study on NCEs, really highlight that there are many opportunities that we actually can change outcomes in patients. We really need to think about how we can integrate some of these very established screening practices as part of routine HIV care. And I think, the implementation scientists here in the room, as well as, out there, really need to optimize their effort in this particular area. It's really very low-hanging fruit for us to change outcomes for people living with HIV as they grow older. And the final point I want to make is on complementing disease-based monitoring with functional assessments. And an example of a framework that we potentially can use in order to guide us in doing this is going back to the assessment of the construct of intrinsic capacity based on WHO's model for healthy aging. And this framework focuses on 5 functional domains. Essentially, what is a person's mood, their thinking, their ability to move, see, hear, and their energy levels. And this construct has actually been validated in a large number of population-based studies, general population, both in high and low middle-income countries, and shown to be able to predict negative outcomes like mortality, increased care dependence, and frailty. But its use in the context of people living with HIV who tend to present these conditions at a slightly younger age has not been very well studied. We assess intrinsic capacity in a subset of participants in the Malaysian HIV and aging cohort, 200 people living with HIV and 100 controls. And we found that across the domains, the only domain that was significantly different was really their cognition. And we then used a very simple scoring, summing up the number of domains that were impacted in an individual. And this has been a published strategy. But we found that when we did this, it tracked quite well in terms of the difficulties in performing instrumental activities of daily living. In analysis using AUC-ROC curve, we also found that it predicted frailty quite well in the Malaysian cohort. And we worked with collaborators in Hong Kong who also did the same study, and we found that it performed quite well as well. So in the small, cross-sectional analysis that we did, this construct seems to work quite well in terms of identifying people with HIV who have care needs outside of the traditional, medical context that we perhaps can use to identify who needs, additional support in our clinics, especially in LMIC settings where we don't have access to geriatricians, the ability to do comprehensive geriatric assessments and so on and so forth. There's a lot more validation work that needs to be done, but certainly something that we want to try to move forward using this construct is looking at it in a larger, sort of more diverse population over a long period of time to see whether it predicts outcome, and also its sensitivity in terms of interventions. So to end my talk, really prioritizing screening and early interventions for NCDs and malignancies in people with HIV is something we really need to look into. And our team is really quite adamant in our conviction that we need to include functional assessments as part of routine HIV care. And this needs to complement disease-based monitoring that we do we do very well now, but we just need to add something else that we need to look into. So I want to thank, I just want to acknowledge my clinical team that I work with, my research team, and really the participants who whom encourage, the most encouraging in terms of getting us to do this work over and over again. And I also like to thank Sheila, Julia, Roman, Jeff, and Rick for supporting this program, CIRA for hosting me today, as well as Fulbright for supporting my trip here to the US, as well as here to New Haven. And I'm happy to take questions.
Julia, please go ahead.
I apologize that I heard your talk in hybrid format, but fantastic work, Reena. So it's really interesting. So I'm going to ask you about interactions that you have.
Hi, the people on Zoom can't hear anything. I don't know if there was a conversation going on.
Back on?
Yeah.
Oh, can you hear us now?
Hear us now?
Yes.
Yeah. Yeah.
Should we just summarize the question?
Okay,
Yeah.
so Julie just asked about, I suppose, people with differing views on whether or not this is more of a biological problem driving the changes of aging versus the environmental factors, and what can you do for both in either or scenarios. I think it's both. I think there are things that are occurring because of biological changes that we really can't do anything about. The virus is driving immune activation. The medications that we're taking are causing changes that, risk profiles in terms of cardiovascular disease, cognitive dysfunction, all of these are going to be there. But there are environmental factors over and above what the virus does to you that also contributes. For one, I think we have dissected this. I think in a lot of the studies that we do, we don't profile the non-HIV related factors well enough. Often we do the clinical part, we profile the NCDs, but we don't talk about the environmental factors, the sleep factors, the exposure to air pollutants, the exposure to heavy metal, and many other factors, social determinants of health that drive a lot of these at a background level. And we know that people living with HIV often are overrepresented in sort of social determinants, and I don't think we have studied these profiles of the contribution of these. But having said that, I don't think it's hard. It is very difficult to separate them out. And I think the way to address this is to understand that they are lived beyond HIV that contribute to this, and there are things that can be done. There are things that, for example, we get a lot of detraction from when we talk about cognitive issues. A lot of clinicians say there's no intervention for cognitive issues, or it's hard to intervene for cognitive issues in people living with HIV. In a low middle income setting, we don't have neuropsychologists, MRIs, and too expensive to do, and so often when somebody presents with cognitive issues, there's very little that we can do with the test. But that's wrong, because you still can address the cardiovascular risk profile. You can still talk about weight management. There are many risk factor modifications. The other thing is we often look at all of this only when somebody hits 40. The point is we have people living with HIV in our clinics from the time they're in the 20s. That's a huge opportunity. They trust their HIV providers a lot. We have a huge opportunity to change and speak to them about all of these background factors that potentially can modulate their long-term outcomes in terms of aging. Every person living with HIV knows the significance of viral load before, because at every consultation that is about. Why don't they know the importance of LDLs and sugar? It should. So there are really opportunities where we can change this trajectory. I mean, the point is, we often look at a single cross-sectional point, but we should really be starting early. And there are many things that we potentially can go. We haven't tried it. It may, I don't know what it's going to look like, because none of us have tried it, but I do believe that there are things that we can do to change, particularly with family.
Yeah, thank you. Thank you so much.
Looks like there's a lot of questions on
Yeah,
line.
there's a couple of
good.
questions on
They're
Zoom.
Oh my gosh, great.
So the first one, how is the Muslim cultural impacting on patients with HIV and their care engagement?
It's an interesting question. I wouldn't put it just to Muslims. I think every culture, every religion has got different practices that may or may not support the lifestyle, perhaps, of people living with HIV. In Malaysia, we come from a multicultural, multi-religious society. We have Hindus, we have Buddhists, we have Muslims as well. So, and when you live in such an environment, there's going to be intersections of different beliefs and practices that somehow seep into the health system, whether you like it or not. That I think to some extent, a lot of in every society we have conservative religious beliefs or sects within the society that drive some of the practices. So in terms of stigma and discrimination, that's still a huge problem, not just in Malaysia, but I think in many Asian countries as well, where religion tends to be very prominent in the way of life in society. So that often spills into the healthcare setting as well. And sometimes we have healthcare providers who these practices may not support, the way they provide services and so on. So it is a problem, but I don't think it's unique to Malaysia. I don't think it's unique to the Muslim culture. But I think it's something that we are consistently trying to address. I think using a human rights approach to everything that we do in terms of making sure everybody gets access to things, regardless of your creed, your religion, and so on, is a safe approach to things. And that's constantly the message that we're trying to.
Yeah, the second question. Interesting findings on loss of intrinsic capability with HIV. You propose routine screening. Is there guidance on when to start, how often? Standardized tools, especially for the cognitive delay.
Great question. And a lot of what has been studied in terms of intrinsic capacity, evidence comes from the general population. And large birth cohorts, they've tested out this model in people over 65 and found it to work very well. There's a huge community in Toulouse, Italy, where they have implemented screening intrinsic capacity as part of the community. So all health clinics in the community do it. Taiwan has introduced it countrywide in the older population. So there's a lot of traction in the general older population, but it hasn't quite gotten into the HIV scene. And I think we have to be a little bit careful there in adopting it in home. For one, I think because in people living with HIV, we tend to see these issues occurring in a slightly younger age. And so the choice of the tools that we use, which has been validated in an older population, whether it performs just as well, whether it's as sensitive to pick up, we're not quite sure. And I think these are the things that we have to test out. The thresholds, I mean, we may use gait speed, but in an older population, the threshold for abnormality might be slightly different from some of them. So these are the things that I think we need more validation, more adjustments. In terms of cognition, you brought up, whoever it was, brought up a very good point. Assessing or screening for cognition has been one of the most difficult things to address, especially in low-middle income settings where English is not your main language, because a lot of the tools that have been validated have come from, English-speaking high-income settings. And actually, that is the subject of my fellowship and why I'm in Columbia, because I'm working with a team in Columbia University led by Ruben Robbins, who has developed easy-to-use app, Open Screen, that transverses all of these issues in terms of language, in terms of literacy, and it's been validated in many countries in South Africa. So we're working with him to do the translation and the cultural adaptation in the 3 main languages in Malaysia, because we realized that using the existing tools, there are issues. We tend to, a lot of we tend to over-identify people with cognitive issues with the current screening tools. So we need, the tools that we have are quite inferior at this point. So this is an aspect, I think, that within the context of aging, an aspect that even within the field of neuropsychiatry and neuro-HIV, there's a lot of contention in terms of what tools you use. Even the classification for the Frascati criteria now is, people have said it's too old, it needs to be renewed. And so there's still a lot of aspects that has not been ironed out there. But at least there's recognition that things need to change. And we just need to keep being nimble and moving forward. But I think addressing cognition is really important. And something that can lead to a lot of downline issues if not addressed.
I think those are the questions.
Could you say a little bit about the work you're doing while you're here at Columbia in terms of brain health and healthy brain aging?
Yeah. So what I mentioned is the project that I'm working with Ruben in terms of doing the translation and the cultural adaptation. And We've done it in concurrently together with MOCA, which is a standard tool for assessing cognition, and we need to do the validation and so on. But at the same time, I'm also working with Ruben to try to address this issue of working out what are the factors that influence long-term outcomes. At least in the HIV field, we know, with yes, it's to some extent a lot of the cardiovascular risk factors that tend to often now come out as a more important factor in current, treat all era where HIV related, apart from the legacy effects, the other HIV-related factors don't seem to often come up as important independent risk factors. That means a lot of the NCDs come up. But a lot of the studies only look at that. They don't look at other social determinants of health, which is so important, particularly in the context of low-income countries. And that is an aspect that we're trying to tease out to put together in the grant and also look at other issues as well.
Thank you, Reena, for a great talk. I think you're doing a lot of things that I wasn't even aware of, so this is fantastic. I think certainly as an HIV clinician, I completely see the utility of the intrinsic capacity model. And I think a lot of us informally ask about a lot of these domains that you mentioned. But certainly having, and many of us use MOCA for cognition, but having a more formal tool to look at all the domains would be fantastic. Tailored for potentially younger populations, as you mentioned. And so I think to the HIV clinicians, this is almost preaching to the choir that this kind of work needs to be done. But a lot of the interventions that you mentioned in terms of screening for NCDs and making sure that we're assessing for age appropriate screening for malignancy and things like that may be different for people with HIV. So that work needs to be done, but I think that's on our radar. I think out in the US there's been a lot of work, and I know you're going to meet with Lydia Bearcat, about thinking about healthcare worker training to take care of people with HIV. But in other settings, I know there's a very distinct domains between people who care for patients with HIV and other primary care issues. And so HIV clinicians, I think outside US are often not cross-trained in primary care, and so I don't know how you see that. And I think the same is true in Malaysia from what I've seen. Most of the people caring for people with HIV are ID trained, and they're not up to date or thinking about cholesterol and cardiovascular risk disease. And so I don't know if those discussions have happened in terms of either integrating HIV in primary care from integrating HIV care into primary care clinicians, or vice versa, up training HIV clinicians about primary care management.
Very interesting point, and something that we've been talking about quite a lot in Malaysia as well. So in Malaysia, the ID physicians are trained in medicine, and then IDs are subspecialty. So they do have the ability to manage lipids and sugar and so on, but they're not up to date with the new drugs. There's so many new drugs for managing all of these different comorbidities, and so and the other model that we have in Asia is where people living with HIV are looked after by primary care providers in health clinics, and they may not have the specialty access to specialty care. It has become clearer to us. So in Malaysia, in UMMC, in where we've been, where I've worked, what we've done is we've set up a multidisciplinary care team, which happens once every month, depending on the number of patients we have. But it looks like we soon have to make it more frequent because we have very, very complex cases. So it's really addressing the complex care needs of people living with HIV, and you've got polypharmacy, we've got declining kidney function, you've got bone health issues, you've got endocrine issues, you've got cardiovascular issues, and you know, the frailty and all of that is coming in as well. So how do you manage these patients? It's becoming clearer to us, at least from the patient perspective, that they prefer their ID connection. And that is where it looks like the focus is going to be. For whether it's due to familiarity with the clinic, not wanting to disclose the HIV status to other clinics outside of the HIV, they prefer to come back to their ID clinicians. And so, at least in Malaysia, we're looking at is having specialties from outside, either sitting in our clinic together or having some sort of a warm handover, so that the patient sees that, okay, so and so knows the mental health specialist, and it helps that transition. But I don't think we can move forward with ID clinicians not knowing anything about it.
Right.
I think it's come to a point where you need to understand at least one of the 3 questions you ask to assess the kind of frailty, some level of condition, so on and so forth. We are trying out a model now in Malaysia where, and it's led by Queenie of our consultants, where we started an echo platform program. And it's for the region of Asia Pacific. And every month we have a different topic. It's frailty, comprehensive geriatric assessments, dealing with urinary incontinence, bone health issues, and we have dialectic lectures from experts. For comprehensive geriatric assessment, we have Eugenia Seger, who, you know, despite the 12 hours, she's still dialed in. And it's subscribed by, it's open to everyone. It's open to clinicians, researchers, whether you're ID, whether you're primary care, whether you are a geriatrician, neurologist, if you are treating patients living with HIV and want to learn more either from the HIV context or from the geriatric context, whatever the other speciality the topic is, you can dial in. And about 40% of our attendees are primary care providers. And so we've got different societies within the region who have agreed to give CID points for it. So it's encouraging a lot of people to sign in. But it's the first time we've tried it, and we realized that it's got a very good response, and a lot of people, they particularly like the case discussions because it's common, it's what they are seeing in the clinic, but otherwise don't have resources. And how that has helped is by organizing, the program, we've now got a group of top members who are connected, who know that, if I need to speak to someone about frailty in the region, this is the person that I go to. So you've developed that network that you can also now write to people and say, I need help with this or whatever and all. So I think it's also one is trying to make things organizing things in a formal way, but also trying to allow that inorganic networking to happen as well. But moving forward, I think every HIV clinician will need to know a little bit about HCAN to some extent, or at least who can I go to within my hospital, within my services that can ask for help if it's such a scenario in because it's inevitable. Sorry, long answer to
No, thank you.
Thank you so much, Reena. We're a little bit past the hour, so let's thank Reena for her wonderful talk. I'd just like to remind the participants to just hang on for a minute as we end the session and answer the questionnaire, the survey, give your input on the session, and look out on the CIRA website for the talk and notes so you can follow Reena and her work as she goes on. Thanks so much again.
Thank you.
I have several questions about